that may come in your exam. So don't let go of these. They are quite important and quite simple. So we'll go system wise. First, we'll do thyroid and breast. And I'll just tell you the IMP points in each. In thyroid, they love asking thyroid cancer. So this can come in surgery or pathology. And remember this point, papillary is the most common type of thyroid cancer overall. It's not follicular. FNAC will diagnose it. You will see cells containing orphananiae nuclei, Samoma bodies, and this is the one which goes to the level 6 nodes. That's a Delphian node. So don't confuse this with follicular. Second thing is, after removing a papillary or follicular thyroid cancer, after you've done thyroidectomy, you must do a radioactive iodine scan. And this is done normally 3 to 6 weeks post-op. And the idea is to look for metastasis. If there are mets present, you are going to give iodine 131 high dose and do a radioactive iodine ablation. So keep this in mind. Breast, of course, there are two favorite topics. One is breast cancer, other is breast abscess. So breast cancer, the important is the TNM staging, in which the T is the important one. And in the T stage, T1 is up to 2, T2 is 2 to 5 centimeters, T3 is more than 5 centimeters. T4 is where you often get confused. T4A is extension to the chest wall, where the tumor is fixed to the ribs or to the intercostal muscles. Invasion of pec major, remember, will not affect the T stage. Similarly, in T4B, it is skin invasion, where you should see ulceration or satellite nodules or a small amount of Pneumothorax, less than one third of the skin. Dimpling, puckering, nipple retraction is not T4B. Okay, it will not affect the D stage. If both of these are there, it becomes T4C. And inflammatory breast cancer is where you have Pneumothorax or skin redness, and it occupies a large area, more than one third. That will be inflammatory breast cancer. This is a PYQ. So at least the T stage is what you should know in the breast cancer. Second thing, in breast abscess, you always get confused between what is mastitis, what is abscess. In mastitis, there is just inflammation. So just some redness, local tenderness, that's it. Antibiotics is the treatment. But in an abscess, you will have a lump. It will be very painful. Abscess means pus. So where there will be pain, it will be fluctuant, it will be tender, fever will be higher grade. And normally, wherever you see abscess, wherever you see pus, it has to be removed. How to remove depends on the quantity. If it's a large abscess, more than 3 centimeters, or more than 30 cc on ultrasound, or it is already leaking pus, in that case, you can put a suction catheter drain. I've shown this image in class, you know, that Romovac drain. Or you can do IND. But if it's smaller than this, aspiration with antibiotics will normally suffice. Right? So remember these IMP points for breast. In trauma, their favorite topics are tension pneumothorax. They keep asking it. Look for these important words: chest trauma, hyperresonance. But just hyperresonance only means pneumothorax. Person should have hypotension. He should have raised JVP. Only then you will call it tension. And this is what will tell you it's a tension pneumothorax. No need to do X-ray. Next step will be put a needle in the triangle of safety, then put an ICD. Okay, that is how you will manage. Don't mistake this for other conditions like simple pneumothorax. In simple pneumothorax, there is no hypotension raised GVP because there is no mediastinal shift. In head trauma, two things you should know. One is if the GCS is 8 or less, you should intubate because it's a severe head injury. EDH, extradural, normally will happen when the injury happens over here. This bone breaks, perion. Underneath the middle meningeal artery will tear. He may have a lucid interval. CT will show this white banana. It will show white idli, not white banana. White banana is acute SDH. So here you will see a white idli. Biconvex lesion, it may have mass effect. If it's a large EDH, the treatment will be craniotomy. Don't go for medical management. Okay, treatment will be remove the blood clot. So that is what you should know for EDH. These are very low hanging fruits. These are the kind of questions which if you make a mistake in, it will hurt you. Okay, so wounds and ulcers. The first thing you are seeing here, this is a vacuum assisted closure or negative pressure wound therapy, where this wound has a dressing applied which is attached to a suction machine which exerts a suction of minus 125 mmHg. So what it will do, it will suck all the pus, the exudate, it will promote granulation, vascularity, everything good will happen. So it will be used when the wound is non-healing. A non-healing wound will become healing. And once it becomes healing, then either you put a skin graft or you suture the wound, depending on how big the wound is. But remember, vac will be put when the wound is not very nice. You want to make the wound smaller. Okay, that is the logic. Second thing is lower limb ulcers. This is the classical one, sole of the foot in a patient with a neuropathy. This is a trophic ulcer. You can make out by the callosity at the border and the deep punched out edges. So look out for this. In head and neck, two topics that they are going to ask you. One is neck dissections. So the most important one is modified MRND, modified radical neck dissection, where you are going to remove level 1, 2, 3, 4, 5 nodes, submandibular gland, sometimes tail of parotid, but you are going to preserve these three structures: internal jugular vein, SCM, sternocleidomastoid, and spinal accessory nerve. They are going to be preserved. In the radical, these three were also removed. Fine, and these are done for oral malignancies normally. And some flaps that they love asking you. This is my favorite. This is PMMC, pectoralis major myocutaneous. It's a pedicle flap. You take tissue from the chest and put it on the face after resection of an oral cancer. It is known as the workhorse flap for head and neck reconstruction. This is PMMC. But what is preferred today are free flaps, right? Radial free forearm flap, free fibular flap, they are preferred because free flaps give the best outcome. GIT is very big, but there are some things which are must know. First is you always get confused Boerhaave versus Mallory-Weiss tear. Remember, Boerhaave is when you have a esophageal perforation, vomiting against a closed glottis. The lower esophagus on the left side will burst, things will leak in the chest. He will get chest pain, he will get that macular striate, so chest pain, retching, subcutaneous emphysema. You do an X-ray, he will have a air in the chest, that is pneumomediastinum. And Boerhaave will require surgery. But a Mallory-Weiss tear happens due to repeated vomiting and retching after binge drinking. So there will be a tear of the mucosa at the GE junction. So he just gets little hematemesis. Okay. Boerhaave, there is chest pain. Mallory-Weiss tear, there is hematemesis. Mallory-Weiss tear is self-limiting. Nothing happens normally. The bleeding stops. Some things about appendicitis. The point of maximum pain is McBurney point, right spinal umbilical line, 2/3 from the umbilicus. And if person has good immunity, the appendix was covered by the omentum, it will form a mass that is managed conservatively. That is known as Ochsner-Sherren regimen. Right? That is known as Ochsner-Sherren regimen. It is conservative management of appendicular lump. Fistula and ano, look at Park's classification: intersphincteric type 1, transsphincteric type 2, supra type 3, extra type 4. These are the four types. Type 1, of course, is the most common, but the IOC is MRI perineum. In olden days, we used to use Goodsall rule, but now to know the anatomy of the tract, you will do MRI perineum. Some images for pilonidal sinuses. This is one of the favorite FMG topics. Like this one over here, the first image, this is called Bascom procedure, where you are going from the side and removing the sinus. Then this one, where you are taking an elliptical incision to remove the tract, this is called Carioducus. And the third image, this one, very famous, this is excision with a rhomboid defect, reconstruction with a rhomboid flap, also known as Limburg flap, which is a type of a transposition flap. In HPB, pancreatitis is their favorite topic. Acute pancreatitis, most common cause is biliary stone. Alcohol is most common cause of chronic pancreatitis, so don't mix them up. The test of choice is serum lipase. Lipase takes little time to rise, maybe 6 to 12 hours, but it is far more specific and sensitive. Remember, neither lipase nor amylase tell you the severity. For severity, you want to do CT, which will be done normally after 2 to 3 days. And then you will see how much necrosis is there. In urology, one of the favorite topics are renal stone crystals. So you must know how they look. The most common stones are these: calcium oxalate, dihydrate. Calcium oxalate, dihydrate have this envelope shape. Monohydrate are dumbbell shaped. Then the second common are your true white or staghorn triple phosphate stones. They are coffin lid shaped. These are the IMP ones. Uric acid, they have variable shapes. They are pleomorphic. They can be, usually they are going to be rhomboid or four-sided. And cystine are hexagonal. These are the ones you should know. And in this, remember, triple phosphate are formed in infected urine. Okay, triple phosphate are formed in infected urine. Cysteine are hard stones. They are resistant to shockwave lithotrops. Second thing in urology, undescended testis, IMP topic. Most common site is high scrotal or inguinal canal, and it should be operated ideally at 6 months. You wait for 3 to 4 months, it may spontaneously descend. And one of the most favorite FMG topics is hernia. Few basic things remember just before the exam. Indirect hernia defect is deep ring, which is a hole in the fascia transversalis. It will go from the deep ring with the spermatic cord, it may enter into the scrotum. Direct hernia is a medial hernia. It comes from a Hasselbalch triangle, which is also a defect in fascia transversalis only. Whenever I'm doing a mesh repair for inguinal hernia, I use Prolene mesh. And I can do open repair, which is called Liechtenstein, which is only repair. Or I can do laparoscopic repair, TAPP, which is pre-peritoneal. In both, we use Prolene mesh. Open repair, most common nerve injured, ilioinguinal. Laparoscopic repair, lateral cutaneous nerve of thigh. Remember these points. And some important things in pediatric surgery, general surgery to summarize. One of the favorite topics is infantile pyloric stenosis. Remember, this will present at 4 to 8 weeks, not at birth. A child will have non-bilious vomiting. It will be projectile. He will have an olive mass, visible peristalsis going from left to right. And the favorite metabolic problem, hypokalemic, hypochloremic alkalosis. Remember to correct the hypokalemia prior to surgery. Surgery will be Ramstad's pyloromyotomy. One of the causes of hydronephrosis in utero is posterior urethral valve. It is seen in male infants where there is a valve in the posterior urethra, so the urinary outflow is difficult. And if the child is born, he may be having hydronephrosis or he will get recurrent UTIs from birth.